Let's consider the anatomy of the heart and the flow of the blood. So the pericardium is a membranous structure that surrounds the heart, and it's composed of the following structures: the fibrous pericardium, the serous pericardium, the myocardium, and the endocardium. And of course, you can remember this word again by referring to your vocabulary words, right? Peri, as in perimeter, means around. So the fibrous pericardium is the outermost layer. It consists of loose areolar tissue, dense connective tissue, and it anchors the heart in place, and the idea is to prevent the heart from overfilling. In other words, if the heart has to stretch as blood comes in, what's to keep the heart from overstretching, from overfilling? So the serous pericardium is a thinner inner double serous membrane that produces the serous fluid. So it consists of, so here is our serous pericardium, right here, right? It folds over on itself, right? And so we have these two layers. So the parietal pericardium is the one more exterior, and the more interior, the deeper layer, is the visceral pericardium. Okay, so the serous pericardium is a thinner inner double serous membrane. It produces serous fluid, and the parietal layer is fused to the fibrous pericardium, where the visceral layer is also called the epicardium. And you'll remember that the word epi comes from the word meaning upon or on top of. Then we have the myocardium. It has two components: the cardiac muscle tissue and a fibrous skeleton. So it consists of the cardiomyocytes, the extracellular matrix, of course, and the fibrous skeleton of dense irregular connective tissue. And the lumen of the heart is lined by the endocardium, and you can see that layer right here. And the endothelium, it consists of endothelium, which is a simple squamous epithelium. It's the third and deepest layer of the heart wall, and the endocardial endothelial cells are continuous with the endothelial cells of the lining of the it is continuous with the endothelial cells of the vascular lumen, and that is the lining of endothelial cells on the inside of the blood vessels. So we have a condition that we can get called cardiac tamponade. It's the result of excessive fluid filling the pericardial cavity. So remember, the fibrous pericardium is strong but not very flexible. So you can at times get excess fluid in the pericardial cavity. So it's not going to allow the heart to expand, right? Because the fibrous pericardium is not going to allow that. So instead, the force exerted between the pericardial cavity and the heart instead is going to be focused inward, and it's going to squeeze that heart. And so cardiac tamponade is the result of excessive fluid filling the pericardial cavity. It reduces the capacity of the ventricles to fill with blood, and that compromises the amount of blood that's pumped with each beat. And so basically, this is a really serious condition. The patient will enter shock. You'll have decreased arterial and pulse and pressure. The neck veins will appear distended. So what you have to do to treat this is you have to take a surgical syringe and tap at a point known as Larry's point, and this will allow you to suck out this excess fluid. However, if it is done incorrectly, you can actually touch the heart muscle tissue, which is going to be disastrous for that patient. It has multiple etiologies. It can be caused by trauma, certain cancers, kidney failure, thoracic surgery, or even HIV. So the heart is supplied by a set of blood vessels collectively called the coronary circulation. So the myocardium is too thick for the oxygen and nutrients to diffuse from the blood inside the heart's chambers. So instead, after the ascending aorta emerges from the left ventricle, you have two branches arising: the left coronary artery, or the LCA, and the right coronary artery, or the RCA. So LCA, RCA. And so these arteries form anastomoses. These serve as a backup route if one of the links is blocked. And by the way, just to quickly cover this, you see the left coronary artery breaks into the circumflex artery and the anterior interventricular artery, also known as the widowmaker. So usually the reason why it has that name is there tends to be accumulation of plaque right at this branching point. And this can lead to a heart attack, obviously, and we'll talk more about that in a second. So this term, anastomosis, it's actually a term that's used throughout science. So when we're talking about how a river at some points comes, apart and comes back together, or we're talking about the structure of anastomoses we see in a leaf, we use this term as well. So collateral circulation is an anastomosis that forms when blood flow to the myocardium is insufficient. So collaterals formed in this manner help to protect muscle cells from damage that could result from blocked vessels. So here you can see a person who has a heart, and all people have hearts, my bad. First, it's a heart where there's a narrowed artery, right? You can see this narrowing right here. Well, let's assume that this person is regularly exercising. What will happen is the body will detect that the blood flow to this section of the muscle is insufficient, and it will start to grow new blood vessels to supply that area as a sort of backup. And we call this backup circulation the collateral circulation. So this is something that really is better reviewed in your book, so I'm not going to spend a lot of time on it, but you can see that each of the arteries provides blood flow to separate areas of the heart. Similarly, different veins return blood return blood from the heart from different regions as well. So a buildup of fatty material called plaques in coronary arteries results in coronary artery disease. It's actually the leading cause of death worldwide, and coronary artery disease results in myocardial ischemia, and the symptoms include angina pectoralis, or chest pain. So MI occurs when the plaques in the coronary arteries rupture and a clot forms that obstructs blood flow to the myocardium. The myocardial tissue supplied by that artery infarct or die. And you can see the symptoms of the heart attack. Of course, these slides are already posted on your blackboard, so I'm not going to go over those. Survival after MI depends on the extent and location of damage. Cardiac muscle cells generally do not undergo mitosis. After an MI, dead cells are replaced with fibrous, non-contractile scar tissue. And so the death of the part of myocardium increases the workload of the remaining heart muscle, right? So that is a huge thing. So remember, these muscles, they don't have the ability to undergo mitosis. So that muscle cell dies, there's no one to take its place. It's just replaced by scar tissue. So the end result is all the other muscle cells around it have to pick up the slack. And that just makes the work of those other cells much harder. So you can do something to reduce some of your risks for CAD and MI, right? So there are some things that you just can't change. You can't change your age. You can't change your gender. You can't change various genetic factors. You can't change your race or your ethnicity, right? Those are risk factors you cannot change. However, if you have high blood pressure, you can get that under control. If you smoke, you can get that under control. If you have diabetes mellitus, you can get that under control. Diabetes mellitus as opposed to diabetes insipidus, right? So diabetes mellitus affects the flow of, affects your blood sugar, right? Physical inactivity. If you are sitting down and watching this video on YouTube, get up and exercise, right? This will help as well. If you have obesity, if you have high blood cholesterol, these are all things that set you on the road to cardiovascular disease. So CAD is definitively diagnosed via angiography. A small tube is fed through an artery in the systemic circuit into the ascending aorta and finally into the coronary arteries. A simple dye is injected into the arteries and a condition examined by X-ray. So here you can see, you can actually see the probe right here where my pointer is pointing. And you can see the LCA, and you can see where the circumflex artery is. And you can see that in certain areas, it seems like there's a little bit of a narrowing, right? And that narrowing is probably indicative of heart disease. So this needs to be fixed. So there are different ways to treat this. So you can have lifestyle modifications or appropriate medication. So you can have an invasive treatment. So that involves coronary angioplasty. So in this case, that same probe that you just used to do the angiograph, you take it, and at the end of that little probe there is a little balloon. You inflate the balloon, and that pushes the plaque out of the way, and this will allow blood to flow through. Another option is a stent. So you still use the same technique with a balloon, but the vessel is damaged enough that just doing the angioplasty alone will not keep that blood vessel from having problems. So you have a stent, which is like a little mesh at the end of the balloon. So when they inflate the balloon, the mesh kind of gets into the blood vessel walls and holds the blood vessel open. And then you can collapse the balloon and pull out. Or you can have a CABG. Okay, and CABG stands for coronary artery bypass graft. So sometimes you'll hear people call it either a CABG, which is more clinical, or a heart bypass surgery, which is more like everyday language. So in this case, you take a little bit of a blood vessel from maybe your leg and a vein from your leg, and you move that to the heart to bypass a blocked vessel. Think of it sort of like a detour, if you were on the highway. So the heart consists of 4 chambers, 2 atria and 2 ventricles. The atria receive blood from the veins and pump blood into the ventricles through structures we call valves. And valves have flaps that close when the ventricles contract, keeping the blood from moving backwards. And the contracting ventricles then inject blood into the arteries, and they carry blood through either the systemic or pulmonary circuit. And 2 large veins drain the majority of the systemic circuit. So here we have the superior vena cava, which drains the deoxygenated blood from veins superior to the diaphragm. And we have the inferior vena cava, which drains deoxygenated blood from the veins inferior to the diaphragm. So we have the pulmonary trunk, which is the largest vessel in the pulmonary circuit, receives deoxygenated blood that's pumped from the right ventricle. All right, so here you can see the right pulmonary trunk. So you see the pulmonary trunk branches into a right pulmonary trunk, a right pulmonary artery and a left pulmonary artery. Once the blood is oxygenated in the pulmonary capillaries, it returns to the heart via a series of pulmonary veins. Notice these veins are red because they carry oxygenated blood. But that doesn't matter. You wouldn't have gotten this wrong because you know that veins bring blood to the heart. And the aorta supplies the entire systemic circuit with oxygenated blood. And the largest structures in the heart are the four chambers. The ventricles are larger than the atria, and they have much thicker walls. This makes ventricles much stronger pumps. There's greater strength needed to generate pressure that pumps the blood around the pulmonary and systemic circuits. So the atria are not symmetrical in size, their shape, or location. So the right atrium is larger, it has thinner walls, and it's more anterior. And the left atrium is somewhat smaller, thicker walled, and located mostly on the posterior side of the heart. So the ventricles are asymmetrical due to the pressure differences in the pulmonary and systemic circuits. Right? So remember, the right ventricle has little resistance against which to pump, whereas the left ventricle pumps against much greater resistance. Since the left ventricle has to work harder than the right ventricle, there is more muscle. And you can see that in this section, right? So the heart has been sectioned here, and you can see the left ventricle has a thick wall and its circular shaped chamber, whereas the right ventricle has a thin wall and it's a crescent shaped chamber. Each ventricle contains papillary muscles which are connected to the chordae tendineae, or the heartstrings, which connect to valves located between the atria and the ventricles. And backflow of blood generally doesn't occur in veins that drain into the atria. The atria are under very low pressure, and the blood mostly flows into the atria with the help of gravity and pressure in the veins. No valves are needed between the atria and the veins that drain blood into them. The backward flow from ventricles into atria is prevented by the right and left AV valves. The AV valves consist of flaps called cusps. They're composed of endocardium overlying a core of collagenous connective tissue. And each valve is named for the number of cusps that it contains. We have a tricuspid valve between the right atrium and the right ventricle, and we have a bicuspid or mitral valve between the left atrium and the left ventricle. Blood is stopped from flowing back into the ventricles by two valves we call the semilunar valves. We have the aortic valve and the pulmonary valve, and there's higher pressure in the arteries and gravity. So you can see blood in the systemic capillaries delivers oxygen to the body's cells. The systemic veins return deoxygenated blood to the right atrium. Blood passes from the right atrium through the tricuspid valve to the right ventricle. The right ventricle then pumps blood through the pulmonary valve to the pulmonary trunk, and the pulmonary trunk delivers blood to the pulmonary capillaries of the left and right lungs, where the blood becomes oxygenated. And the pulmonary veins then return the oxygenated blood to the left atrium. Blood passes from the left atrium through the mitral valve to the left ventricle. The left ventricle then pumps through the aortic valve to the aorta, and then the aorta delivers blood to the systemic capillaries, and the cycle continues. So we can have sometimes valvular heart diseases. These are diseases where which impair the function of one or more of the valves. They can be congenital, or they can be acquired as a result of a disease process such as infection, cancer, or immunodisorders. There are two major types of valvular defects. We have insufficient valve and a stenotic valve. Both types of valvular heart diseases can cause a heart murmur, which is an audible swooshing of blood when the heart beats. Other signs and symptoms vary with the type and severity of the disease, and the mitral and aortic valves are the ones most commonly affected.